ACR is listening to its members and rolling out a new and simplified membership model designed to add value no matter where you are in your career. Find out more at rheumatology.org. ACR and ARP, where membership means excellence. Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. Sometimes looking out a different window and reframing our perspective is good. Today, we will explore how scientists are reframing pain, applying new perspectives to the management of pain in rheumatology, and advancing the science of pain in our field. The manuscript we will discuss today is Identifying and Managing Nociplastic Pain in Individuals with Rheumatic Disease via a Precision Medicine Approach, a narrative review. It was recently published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. I'm excited to be joined by one of the co-authors of this manuscript and one of the greats in our field, Dr. Dan Klaw. Dr. Klaw is a professor of anesthesiology, medicine, and psychiatry at the University of Michigan. He attended undergraduate and medical school at the University of Michigan and completed his internal medicine residency and rheumatology fellowship at Georgetown University in Washington, D.C. He then rose through the faculty ranks at Georgetown, becoming chief of rheumatology and vice chair of medicine. During that time, he assembled an interdisciplinary team focused on studying the role of the central nervous system in several chronic pain disorders, including fibromyalgia, interstitial cystitis, low back pain, and Gulf War illness. In 2002, Dr. Klaw and his research team moved to the University of Michigan, where he led the Chronic Pain and Fatigue Research Center and was tasked with growing the clinical and translational research infrastructure serving the University of Michigan. He was the first PI of the University of Michigan Clinical and Translational Sciences Award, CTSA, and founding director of the Michigan Institute for Clinical and Health Research. He is currently co-PI of 2 NIH Center grants, studying mechanisms of chronic pain in neurological and musculoskeletal disorders, and he is an active mentor of many clinical and pain researchers. Welcome to the show, Dan.
Hi, Vicky. How are you?
I'm doing well. So before we start, just by way of full disclosure, I do want to clarify for our listeners that while Dr. Klaw and I were both alumni of the Georgetown University Rheumatology Fellowship Program, and at different times we were both on faculty at Georgetown, our tenures did not overlap. Another connection that many people don't know is that I now live on the same road that Dan used to live on when he lived in the DC area. This is very esoteric DC area knowledge. Some might say it's even inside, outside the Beltway knowledge. However, Dan, you will be pleased to know that the one-lane wooden bridge is still there and it still floods pretty much every year.
Well, I won't say the name of the road, but it's a beautiful road. You must have a nice house, so that we can go.
It's a beautiful place to live, and I drive past your old house pretty frequently. So now I was excited to see that this manuscript was selected by the editors because pain is a widespread problem, not just in the practice of rheumatology. And so many times we struggle to understand the mechanisms and etiology of pain. So I wanted to start by having you bring us up to speed on the terminology you use in this manuscript. I think it's based on some 2016 recommendations to classify pain into 3 broad categories: nociceptive, neuropathic, and nociplastic. Could you tell us about those 3 types of pain and how rheumatologists can better recognize them in their clinic?
Sure. So nociceptive pain is the kind of pain that most people think all pain is, and that is that the pain is due to some type of damage or inflammation in the area of the body where you're experiencing pain. And so we've known forever about nociceptive pain. We've also known for a long time about the second pain mechanism is neuropathic pain, where the pain is either due to dysfunction of a nerve or a pinched nerve. But this third mechanism of pain, which in 2016, the International Group of Pain Researchers invented the term nociplastic. Many of us don't particularly like that name or that term, but it's here to stay. And this kind of pain is best exemplified by conditions like fibromyalgia, where the pain is really coming more so from the central nervous system, the spinal cord and the brain, rather than it being due to some type of damage or inflammation in the periphery or some type of dysfunction or damage of a peripheral nerve. And so this is sort of a big deal in that conditions like fibromyalgia, irritable bowel, tension headache, temporomandibular disorder, and even many cases of sort of low back pain, vulvodynia, interstitial cystitis are now thought to have that third mechanism of pain, nociplastic pain, as the mechanism that's really front and center. And this used to be called things like central sensitization or centralized pain, terms that I actually like better because I think at least clinically people understand when you say centralized that you are inferring that the pain is coming really from the central nervous system.
Yeah, although nociplastic at least does suggest that it's modifiable or adaptable. So can you help us understand how those new categories interplay with the concept of top-down and bottom-up frameworks of understanding pain, particularly in rheumatology?
Yes, so a long time ago, we used to delineate fibromyalgia into primary fibromyalgia, which was individuals with just fibromyalgia, if you will, or fibromyalgia plus some irritable bowel and headache, but no identifiable autoimmune disease, for example. And then we would use the term secondary fibromyalgia for individuals with rheumatoid arthritis or lupus or osteoarthritis or sickle cell disease who started out as having a peripheral pain syndrome or a nociceptive pain syndrome, but over time, they really developed this sort of secondary fibromyalgia, secondary nociplastic pain. Those terms, primary and secondary fibromyalgia, were sort of abandoned. And so our group and others have used terms like top-down to indicate what used to be called primary fibromyalgia. It's probably starts as more of a brain problem. And individuals with primary fibromyalgia or top-down fibromyalgia often will start developing symptoms in their teens or in their early 20s, versus the bottom-up form of fibromyalgia is what used to be called secondary fibromyalgia. And these are individuals that may start with a condition like osteoarthritis or rheumatoid arthritis or lupus, and over time develop secondary fibromyalgia, which really looks the same on functional brain imaging and with respect to what that means from a treatment implication standpoint. But again, these bottom-up individuals, it seems to be that their fibromyalgia or nociplastic pain is really being driven by something that is occurring out in the periphery.
And actually, that kind of brings me to my next question of most of our patients that we see in the clinic kind of cross that spectrum where they may have started, for example, even with rheumatoid arthritis or lupus, where there was an active inflammatory process causing the pain, but then over time developed this kind of coexistent disordered pain processing. And so as you've evolved in understanding those new frameworks, how do you as a clinician tease this out at the bedside, and how important do you think it is to tease it out as a clinician?
I don't think it's that important to tease this out as a clinician because, as I alluded, right now we can't really tell much difference between what we used to call primary fibromyalgia and secondary fibromyalgia with respect to what drug and non-drug treatments are going to work. And so I don't think it's as important for people to say, in this person, it's top down versus bottom up. I think it's more important that people learn to identify when someone has comorbid fibromyalgia, comorbid nociplastic pain, because again, then they are going to have to treat that person differently. They're going to have to use more treatments that are aimed at the central nervous system.
Yeah, so it's really understanding the kind of facets of the problem so that you develop a multifaceted approach to the solution, it sounds like.
Exactly.
And can you also explore for us some of the advances in precision medicine and pain? We know there is a heritable component to fibromyalgia and some of the disorders of central pain processing. Are we any closer to understanding the genetic underpinning of these pathways, and how can we put that into context for our patients?
It turns out that a lot of chronic pain conditions, especially these nociplastic pain conditions, are very familial and very hereditary. Twin studies of conditions like fibromyalgia and irritable bowel have suggested that about 50% of the risk of developing one of those conditions is environmental and about 50% is genetic. But there's no single powerful genes. A lot of studies have been done recently using things like the UK Biobank and developing what are called polygenic risk scores, where a number of different genes in combination will either increase your risk of developing something like fibromyalgia or decrease your risk of that. But it's no single gene that we can look for. And, like in a condition like cystic fibrosis, the Mendelian transmitted, this is really combinations of hundreds of genes that either, if you will, turn up someone's volume controller amplifier in their brain or turn it down.
Yeah. So a little bit further away than in some other disorders, the precision piece of that, then it sounds like.
Yeah, although I think right now we can start to move in a precision direction by using really simple things like giving a patient with chronic pain a body map and seeing how widespread their pain is. There's a lot of data now that suggests that that measure alone will be highly predictive of whether a peripherally based treatment like surgery or injections or opioids is going to work, or if someone has more widespread pain on a body map, not just a pain in a single site, but the more widespread the pain, the more likely the pain is coming from the brain, and the more likely that you're going to have to use drugs that work in the brain, like serotonin norepinephrine reuptake inhibitors, gabapentinoids, tricyclics, and a lot of non-drug therapies. These individuals with conditions like fibromyalgia, that's probably been the other big thing in the broader pain field that's changed the most, in addition to the sort of legitimization of this third mechanism of pain, is how effective a lot of the non-pharmacologic therapies, the non-drug therapies are across pain syndromes, but especially in conditions like nociplastic pain conditions, fibromyalgia.
Yeah, so actually let's talk a bit about treatment. So how have the treatment paradigms changed over the last 30 years, and where are we clinically borrowing from that Georgetown motto of cura personalis and caring for the whole person when we manage chronic pain in the rheumatology clinic?
Well, there's certainly a subset of individuals with autoimmune diseases that most of their pain, or maybe all of their pain, is nociceptive. It's coming from inflammation from their autoimmune disease. And when we treat those individuals with all the really excellent drugs that have been developed in the last 10 to 20 years, those people get quite a bit better. But we all know that there's a large subset of people with those same autoimmune conditions that even after we successfully treat their inflammation, they have a lot of pain, fatigue, memory problems, sleep disturbances. They have that nociplastic pain phenotype. And those are individuals where we really should treat them just as we do people with fibromyalgia, use the same drugs that I talked about earlier, and keep opioids away from individuals with nociplastic pain or fibromyalgia, because it's not just that they don't work, they actually may make these individuals worse. But when you see that your patient with rheumatoid arthritis or lupus has what we used to call secondary fibromyalgia, what we now call nociplastic pain, really get aggressive about getting them sleeping better, getting them more active, and then again, using a whole cadre of therapies, non-pharmacologic therapies, many of which we used to be dismissive of because they started in the East: acupuncture, yoga, Tai Chi, mindfulness. A lot of those treatments really have increased tremendously with respect to their evidence base. And those are now actually not even called complementary and alternative therapies anymore. They're called integrative therapies, because we really should be trying to figure out how to integrate those treatments into the care of all of our patients with chronic pain.
Yeah, so much. And it's like we've come full circle as a profession, right? That now we've finally figured out that you do have to care for the mind, the body, and the spirit in order to help people feel whole. Can I get you to speculate a little bit now about what the future might hold for chronic pain? Are there any things that you see coming down the pike?
Well, we think that a lot of these integrative therapies can be delivered fairly easily to patients, either just using the internet or smartphone apps, or maybe with a little bit of time with a health coach. And so certainly a lot of the care models that we're promoting and some of the research that we're doing is, instead of taking these non-pharmacologic therapies like cognitive behavioral therapy or acupuncture or acupressure and using them one at a time in individuals, we're now thinking about bundling them using what we call multi-component therapy and offering patients a number of the integrative therapies, and then let them choose which of those they want to try. I was quoted recently in a New York Times piece that Nicholas Kristof did, saying that in people with chronic pain, there's 15 or 20 non-pharmacologic therapies now that have a big evidence base. And the main thing we need to be doing is encouraging them to try new things. I don't tell people whether they should try cognitive behavioral therapy or acupuncture or Tai Chi or yoga or meditation, but I do tell them that here's a list of these 15 or 20 therapies, and you should be trying 2 or 3 new treatments along these lines every year until you feel a lot better, because we don't know now who's going to respond to acupuncture, who's going to respond really well to mindfulness. All we know is that about 1 out of 3 people on average respond to any of those non-drug therapies.
Yeah, and I kind of wonder actually whether some part of that is this giving the patient back their locus of control and being able to give them ownership over this is the issue and this is how my body handles it and this is a treatment that works for me.
Well, and along those lines, one of the things I'd suggest to the providers that are listening to this is change how you talk to your patients about their pain. And if you're in a setting, for example, where you're asking people their visual analog pain scores or things like that, that's fine. You probably have to do that somehow for documentation. But it's never going to motivate someone with pain or fatigue to get better by telling them, I want your pain score to go from a 7 to a 4. What you need to do is you need to ask them, what are a couple things that you're not able to do right now that you'd really like to be able to do? And use those goals, those functional goals that patients have as a motivation for getting them to try new things. I think we really sometimes don't think very carefully about like what it takes anyone to be motivated to change their behaviors, any of us. And so I think, again, thinking about ways where we sort of flip things around, like you were saying, you're changing the locus of control, is that you very much put which of these non-pharmacologic treatments do you want to try, Mrs. Jones, under their control? And what are the functional goals that you want me as your provider to help you attain? But again, we're not going to be chasing pain scores here. We're going to be chasing, you want to be able to hug your grandchild or play 9 holes of golf or something like that. And patients may do a lot more to attain those goals than some of the ways we've tried to motivate them in the past.
And I think that's so helpful as we think about kind of these interactions with our patients and giving them an opportunity to tell you what success looks like for them, and then also giving them a chance to kind of self-author what they want this part of their story and their success to look like, I think is really important. I love it.
And get people to be aware that the psychologists and others that have developed different types of strategies, cognitive and behavioral strategies, figured out a long time ago that if you can start with things that are simpler for people to do and give them early wins, that helps a lot too. So one of the things I strongly recommend is that if someone has chronic pain, first of all, you don't use the word exercise with them to talk to them. You use the word activity, because they find that a lot less threatening to ask them if they can get more active by just walking around or moving or things like that. And tell them, because this will often happen, is that if you're just able to increase your activity, the first symptom that's likely to get better is your fatigue before your pain. Because if anyone that sits around, we all learned that during COVID, that if anyone that just sits around all day and doesn't move is going to be tired. But start with simple things, behavioral and cognitive strategies that are really simple. And if you can get your patients some early wins, then you can reel them in and then get them more and more motivated to say, wow, these things that I can do really make a big difference in how I feel. And because of that, I'm going to do more of these things.
Yeah. And actually, that's probably something where the health coach model is really, really useful, just because it allows the patients to have a partner in the process outside of the clinician.
We think that websites and apps alone are always going to have sort of limited effectiveness, that just having a human, in part because all of us are more accountable. If we tell someone else that we're going on a diet, we're more likely to follow the diet than if we just on our own say we're going to do it and then we just trash it. But having another person like a health coach, I think in a lot of practices, if you don't have a health coach, a lot of mid-level providers like working on these kinds of things with patients. But another strategy I would have more broadly for rheumatologists or other providers that maybe don't feel that comfortable managing chronic pain right now is when you go in the exam room, don't manage the pain, manage the sleep problem, the fatigue, the memory problems, the lack of activity that the individuals have, especially these nosoplastic pain patients. But you sometimes find them frustrating because they have these other symptoms, but maybe turn that around and look at that as an opportunity. Is it maybe on one visit you entirely focus on fatigue, or on one visit you entirely focus on sleep and improving sleep? And again, you'd be surprised because these things are so intertwined that sometimes the therapies aimed at some of these comorbid symptoms can actually be incredibly helpful for the pain.
Yeah. And I guess the flip to that would be focus on the thing that's most important to the patient that day too, right? That they should be able to say to you, I really need to address the sleep today, or I'd like to find ways to be more active because I'm going to see my grandkids.
Exactly.
So I wondered if we could change tacks a little bit now. I like our listeners to get to know the people behind the papers, and I wanted to give you a chance to talk about your career. As I mentioned, you're originally from Michigan and then moved to Georgetown for residency and fellowship, eventually joined the faculty and grew your program from there. You were chief of rheumatology and vice chair of medicine, both roles that many people would consider to be the pinnacle of a career. What made you decide to leave and go back to Michigan?
That's a great question. And much of it was the ability for me to go home. And my wife, we both went to undergrad and graduate school at the University of Michigan. So for us, it was an opportunity to come home. But it also was an opportunity to go from Georgetown to the University of Michigan. I love Georgetown, but the scientific environment for doing interdisciplinary science is really unparalleled at Michigan. And so bringing our group to the University of Michigan really allowed us to expand our science as well. And I joke about this, but it's not really a joke, is I wasn't trained to be a researcher, and some of the amazing training programs that we have now for junior faculty that are wanting to go into research were not available when I was coming up. And my mentors, Paul Katz, David Nischel, Tom Cupps, were as helpful as they could possibly be. But again, we didn't have the training programs that we have now. And the reason that I embraced team science is I didn't know how to do science. So I found Dave Williams, who's a psychologist, and Rick Gracely, who was up at the NIH doing functional brain imaging, and invited them to join our team, which grew and grew and grew. And by the time we did move the Chronic Pain and Fatigue Research Center from Georgetown to the University of Michigan, there were 12 of us that moved from Washington, D.C. to Ann Arbor in 2002. And that team has continued to grow, but all of my success has been by adding faculty that bring different types of expertise, different types of disciplines. But some of the people in our group now are epidemiologists, or they're trained in all sorts of neuroscience, all sorts of different disciplines, data science, and they really can do just better and better team science because of that training.
Yeah, and I think that's really good advice, that both for people who are starting out and then people who are mid-career in the growth and team building process. Could you share with our listeners what moving your research program was like? There are definitely phases of a move where you kind of have that, oh my gosh, what have I done moment, because you feel like you've got to rebuild everything from scratch. How did you personally approach that? And do you have any tips for our listeners facing those challenges?
It's difficult. If you're doing clinical research, it's going to take at least 2 years for you to sort of get up and running again. And maybe even at that, you're not going to be running at the same pace that you were when you left your other institution 2 years ago. But just getting all the required IRB approvals, regulatory approvals, getting new staff hired is going to take a considerable period of time. So just make sure that you have time for that. And that's one of the nice things about some of the career development awards, where people have 75% protected research time, and it allows them to set up the infrastructure, hire the people and set up the infrastructure they need to do really high quality team science. An alternate approach is to become a member of a bigger team. The people, for example, that join the faculty in our research group don't have any trouble becoming independent and autonomous from me or from any of the other people on the team. And so it used to be said that in order for you to get tenure and get promoted and things like that, you had to be autonomous and independent. You have to have expertise that's, for example, at the University of Michigan, the people in our group all have expertise that's different than mine, because, again, I'm coming at this from more of a 30,000 foot standpoint, and a lot of them are coming in with deep expertise in functional brain imaging or quantitative sensory testing or immune function or any number of things, cannabinoids or psychedelics, any number of things that we're doing research in, but they might have, for example, gotten a PhD to really have deep knowledge in that area or in those methods.
Yeah, that's really good advice. And at Michigan, you hold several academic appointments in different departments, including anesthesiology and psychiatry. Could you speak to the advantages and disadvantages of dual positions? And do you have any tips for people who work in similar cross-disciplinary fields on the pros and cons of the dual appointment?
At Michigan, there's no disadvantage of having dual appointments. My primary appointment now is in anesthesiology because most pain research groups are in anesthesia departments rather than in rheumatology divisions, which, again, from whence I came. But any number of departments at the University of Michigan would like someone like myself to have a secondary appointment in their department because of all the grants I have, and then it helps counting their grants. So my real relationship at Michigan is with the Department of Anesthesiology, which is my home department, and I still do a lot of work in rheumatology with the Division of Rheumatology. But again, I have an appointment in psychiatry as well, but I don't really have to do anything in the Department of Psychiatry. It's what we call a dry appointment.
Mm-hmm. And since you've been at Michigan, you've filled several senior research and leadership roles for them. I'm kind of fascinated by how productive people decide what opportunities to pursue. And I wondered if you could tell us your experiences about how you decide what to do. And more importantly, when and why and what do you decide to stop doing?
Well, let me answer the second question first, because I mentor a lot of people. That's primarily what I do now, and it's an amazing job that I have, just being primarily a mentor. And one of the first meetings I'll have with every mentee is to tell them that they have to develop a not-do list. Everyone has a to-do list, but people aren't good about giving up archival commitments that maybe made sense to agree to do this a year ago or 2 years ago or 5 years ago, but it actually doesn't make sense for you to continue to do it. And so I think it's really helpful. And now, as we more and more use electronic calendars, go through 2 months of your electronic calendar. And every time you see something on the electronic calendar that maybe it causes the hair on the back of your neck to stand up, or you just get this yucky feeling, put it on your not-do list. You don't really want to keep doing that, and you need to figure out a way to get out of it. And the other thing I would say, you struggle about telling people that you want to get out of this, that, or another thing. But when you tell them you're going to do it, they just say, okay, do it, just do it. So anyway, be aggressive about shedding those archival commitments, because if you don't, then you can't do new things, or you don't spend time with your kids or your wife or your family. And so you have to do that as a survival tactic, first and foremost. And I would say that the way I've historically, and certainly the way right now at the current point in my career, make decisions is, do I want to do this? Is this something where I can be impactful? Either by talking to a single person and helping mentor them, being on a committee where I think that my presence on that committee will make a difference. But I screen my commitments very carefully through the lens of, is this something where I can be impactful? And a secondary thing is this going to be fun? Because it turns out that many of the things that I get an opportunity to do these days are both impactful and fun. And so I can screen using both criteria. But it's very freeing to get to a point where that's your primary screening criteria. But you have to be really good about pruning your historical commitments, or you can't be like that.
Yeah, I think that is such good advice. And as you were talking, I was actually visualizing, you don't want to be like a museum where you've collected all these relics of things that you do and serve on and roles that you have that you're not deriving joy from anymore. They're just gathering dust. So such good advice. Thank you. Along those same lines, we often don't talk about medicine and how we evolve professionally after we finish our training. It's been about 33 years, I think, since you finished your fellowship, 21 years since you left DC and moved back to Michigan. What have you learned during that time that's shaped you into the physician and scientist you are today and helped you really grow both vertically and horizontally as a physician?
Be a good human. I think it's really important to model to mentees and trainees just to be a good human. I'll say again, be nice to people, be helpful to people, be empathetic. And it comes around. It really does. I think I actually am inherently nice and friendly, and I'll mentor almost anyone that asks me to. But I can't tell you how many times that's come full circle where that person was able to be helpful to me. And I just think that people need to be like just mindful. Don't be running around like a chicken with your head cut off. Try to keep time for yourself and think and reevaluate what you're spending your time on and how important that is and what you might be able to be doing instead that would be more fun for you and maybe more impactful to others around you or others in the world. But constantly be challenging yourself about, is what you're doing now optimal for like where you are in your career, where you are in your life, what you want to be doing. I think a lot of people get stuck in ruts. I've given up several leadership positions that no one else at the University of Michigan gives them up once they have those positions. And it's really fun to do that and then move on. You free up time to do new things and to take on other sort of opportunities. And so I'm not good at doing the same thing over and over again. I think I'm really good at sort of figuring out myself, what I'm good at, what I'm not good at. Surround yourself with people that are good at doing the things that you're not good at doing. Create your teams and your villages, and you can do really impressive things.
Yo, such good advice, Dan. Thank you. Thank you for sharing all of that and for joining us on the show. I've always enjoyed talking to you and hearing about your advances in pain research. And I just want to thank you so much for sharing your experience and your wise career advice.
Thanks for having me.
In this episode, I also want to thank all of those researching pain and rheumatic diseases. It is one of the most challenging aspects of rheumatology research, but it has enormous potential to impact the care of our patients and is so greatly needed. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.